It is a pleasure for me to welcome Dr. Michael Mithoefer. He came the long way from Charleston, South Carolina to talk to us about global progress on MDMA-assisted psychotherapy. Michael Mithoefer was trained in internal medicine and emergency medicine, and then in the emergency room, he decided that he wanted to help people before they get seriously hurt, and then he became a psychiatrist. About the same time, he read Stan Grof, and he is also a certified holotropic breathwork therapist. Facilitator, sorry, yes. Michael has done a couple of studies in the meantime, since 2004, since his first study. He's part of MAPS, and they have a lot in the pipeline. And the aim of MAPS is to develop MDMA into a prescription medicine. Michael will talk to us about these issues too. And now I will say something in German. Michael Mithoefer ist ein amerikanischer Arzt, der zuerst Innere Medizin gelehrt hat und dann auch Notfallmedizin und dann sich entschlossen hat, noch Psychiatrie zu lernen, um den Menschen besser helfen zu können. Er ist Holotropic Breathwork Facilitator, hat bei Stan Grof gelernt und jetzt der Mann bei MAPS, der die Studien leitet. Er ist uns verwandt, seine Ahnen kommen aus Bayern, wie der Name vermutet lässt, so eine schöne Verbindung. Wir werden entgegen der Ankündigung im Programm den Vortrag von Michael nicht fortlaufend übersetzen. Das wäre zu zeitraubend und störend. Wir haben dafür seine Folien auf Deutsch übersetzt. Im Anschluss daran, an seinen Vortrag, gibt es auch in Abänderung des Programms kurze Fragen und dann ein Schlussstatement aller Referenten des heutigen Tages. Michael, please.
Thank you. Well, thank you, Peter. I don't know what you said, but we've been friends long enough, so I guess it's probably not too bad. The only thing I might add after hearing Vanya's comments is that I was one of those hippies in the 1960s that went below the surface, and I'm still here. And I don't think I would be doing this work if it hadn't been for my experiences with psychedelics in those days. So I really want to thank Peter Gasser and all the members of SÄPT for inviting me. It's really an honor to be able to speak at your meeting. I know that MDMA work was going on here by your group in the 90s before we started our research. So it's, and being near Albert Hoffman's home, it feels like the right place to be talking about this. Thank you, Peter, for translating all my slides. So I want to talk to you a little bit about the research we've been doing. We've been working on it for almost 15 years now with MDMA-assisted psychotherapy for people with treatment-resistant post-traumatic stress disorder. And as you see, it's our research is sponsored by MAPS, so Rick Doblin deserves a lot of credit for this. And I do this work with my wife, Annie, and she couldn't be here this time, but she's very much been a part of this as well. So I'm just going to mention a little bit about why we thought it was a good idea to study MDMA for PTSD, and then I will tell you about something about our completed studies and the study design, and then our ongoing studies. And then I have some quotes from study participants that speak very eloquently. I hope I'm okay to be understood. I didn't mention I don't speak German, obviously. My great-grandfather was born in Bavaria, and my grandfather in the late 1800s came back to Germany to go to medical school, but unfortunately I never learned German. But since my family is from the south of Germany, even in English, I can't speak as rapidly as Torsten. So, yeah, why? Well, let's see. Got to remember which slide is which in German. Just a little bit of about the research. When we started working on this, there was already a lot of preclinical data in animals and data in recreational users of MDMA. So this was one of the actual advantages of having the governments concerned about MDMA. They spent a lot of money on preclinical research. So Rick Doblin didn't have to raise the money for that. And then when we started, there had been 3 phase 1 trials giving MDMA to healthy volunteers in the US. Charlie Grobe did the first one, and there were a number in Europe. So we didn't have to start there either. So where we started was phase 2 trials, which means the first time you get permission from FDA to give a medicine to people to treat a specific condition. So this was our first one, which I'm going to tell you about, was published in 2010, and then long-term follow-up, and then Peter and Verena did a study around, overlapping with us. Here is a kind of give you an idea of where we stand now in the worldwide phase 2 trials and the number of people. The first one is our study in Charleston. The second one is Peter and Verena's study in Switzerland. Those 2 are completed. And then the others are now going on, and most of them are almost completed. One in Vancouver, the other one we're doing now in Charleston, one in Israel, and one in Colorado. So it's a total of about a little over 100 people in these trials at this point. So why did we think it was good to study MDMA for PTSD? Well, for one thing, we really need better treatments for post-traumatic stress disorder. At this point, with the existing treatments, I think it's close to 50%. Half the people do not respond to existing treatments. And psychopharmacology, existing pharmacological agents are not very good at treating PTSD. They may decrease symptoms, but they don't get at the heart of the problem. And all the therapies for PTSD involve revisiting the trauma in psychotherapy. And sometimes that works quite well, or even very well without MDMA, but often it doesn't. And some of the reasons for the obstacles to successful treatment are fear. On the one hand, people with PTSD can easily be overwhelmed by anxiety, or conversely, they may have a lot of emotional numbing, so they can't emotionally engage when they revisit the trauma in therapy. And there's lots of evidence from other types of therapy that show if they're overwhelmed by anxiety or they can't engage emotionally, the therapy doesn't work. And the other big factor is difficulty trusting and forming a therapeutic relationship with the therapist. So those are some of the main obstacles to success in therapy. And so it made sense to us, if MDMA decreases fear and defensiveness and increases trust, it might be very good for overcoming the obstacles for people who have not responded to existing treatments, because all these studies are only treating people who have failed prior treatment. And then also MDMA usually helps people have some very positive affirming experiences, which can help them kind of correct their negative distortions and feelings about their life at the present time. So that was our thinking when we started out. Torsten has talked about the mechanisms. I just wanted to say one thing about part of what seems to happen is has to do with this idea of level of arousal. And this is from Pat Ogden, and others have described this in other kinds of therapy, that if people are hyper-aroused, that's when they're overcome by fear, their processing is disorganized, they can't effectively address the trauma in treatment. Conversely, if they're hypo-aroused, they're emotionally detached or emotionally numb or dissociated, they can't process it either. So there's this idea that there's a kind of a zone in between called the window of tolerance or the optimal arousal zone, and that's where therapeutic change can happen. So part of the way we understand what seems to happen in the MDMA sessions is it gives people a few hours in this optimal arousal zone in which they can finally process the trauma effectively. So this is, I want to talk about, this was our first study, studying MDMA-assisted psychotherapy for 20 people with treatment-resistant PTSD. And just to give you an idea of the approval process, we first got approval from the FDA in 2001, and then it took a while. It's a long story, but it took a couple more years to get IRB approval, and then even longer to get DEA approval. This big delay is not happening anymore for our current studies, but in the beginning, it seemed as if they were kind of hoping if they stalled long enough, we would go away. But those of you that know Rick Doblin know that that was not going to happen. We finally got permission. We enrolled our first subject in 2004. We finished the study in 2008 and published it in 2010. So our hypothesis was pretty simple, that we could give MDMA safely to people with severe PTSD, and that it would decrease PTSD symptoms 4 days after each of 2 MDMA sessions and 2 months later, according to standard measures. It was a double-blind, placebo-controlled protocol, 20 treatment-resistant people. Yeah, this is the right one, isn't it? Yeah, okay. And it was crime or war-related PTSD. Oh, okay. This is what I want. Sorry. That says double-blind, placebo-controlled. 20 treatment-resistant people. PTSD could be from either crime or war. In this study, it was almost all crime-related, either childhood sexual abuse or rape or assault. And in this group, the average duration of PTSD was more than 19 years. So people had to have failed psychotherapy and medications, and usually most of them had had years of therapy and many, many medications. And we did careful medical and psychological screening before treatment. So the way the study worked, the first stage was double-blind. 60% of people received MDMA on 2 or 3 occasions. It started at 2 and then we moved to 3 later, but I won't go into those details. And 40% got inactive placebo on 2 occasions. We used the same primary outcome measure that Peter was describing, the clinician-administered PTSD scale, the CAPS, and then we did these other measures, but today I'm going to just focus on the CAPS. That was the most important one. All the screening and outcome measures were done by a psychologist independent of the treatment, who wasn't involved in the treatment, didn't know what happened in the treatment. And this diagram just kind of shows the way the study worked. That after screening, people were enrolled, and then they would have 3 preparatory sessions with the 2 therapists, myself and my wife in this case. So 3 90-minute sessions to prepare them for the experience. And then the yellow triangles are the MDMA sessions, a month apart. So 3 preparatory sessions, then an all-day MDMA session, and then 3 follow-up integration sessions, we call them, to help people integrate the experience and support them afterwards. And then another MDMA session, 3 more integration sessions, and then 2 months after that, the psychologist repeated the testing to measure the symptom levels at that point. And then after we broke the blind, if people had gotten inactive placebo, they could go back to the beginning and go through it again with open label MDMA. If they had had 2 MDMA sessions, then they could have 1 more open label MDMA session with the same integration sessions afterwards. And then we measured the levels 2 months later originally, and then later in a longer follow-up that I'll tell you about. So the MDMA, people did not get MDMA to take home. It wasn't something you take every day. They only took it these 2 or 3 times under direct supervision in our office with 2 male and female therapists present the whole time. We measured their blood pressure and pulse very frequently, more frequently than we thought, but the FDA wanted us to do that. And the dose of MDMA was 125 milligrams, followed by an optional supplemental dose about 2 hours later of half of the original dose. And then they stayed overnight in the clinic with a night attendant. We met with them the next morning before they'd go home for an hour and a half at least. We would call them every day on the phone for a week, and then we would meet with them 3 more times before the next MDMA session. Yeah, that's enough of that. So our therapeutic approach was quite non-directive, kind of aimed to support the person's own experience rather than direct it. And people would often be reclining using headphones and eye shades part of the time to listen to music and focus inward. And then we would have alternating periods of talking to the therapist and going and focusing inward. There was no schedule for that. It varied quite a bit from person to person, but we thought it was very important to have quite a bit of time focusing inward and then some time talking to us. And we've now written a manual that describes our approach, and it's based, it's really our adaptation of largely what we learned from Stan and Christina Groff in our training with them, and also many others who went before. And this manual is available without charge at the MAPS website. Here's where we do the sessions. So the people lie there. We sit on either side. You can see the blood pressure cuff and the eye shades and headphones. It's a very private, quiet, comfortable place. And, what it seems to us that MDMA magnifies whatever is there. So people may have really affirming and joyful experiences. They also may have difficult, painful experiences. And usually most people have some of each. And we actually think we don't have a preference for one. I mean, the affirming ones are more fun, but we really think both are very important for the therapy. Several people in the first study said this: I don't know why they call this ecstasy. So that's just to emphasize the point that it's not just that they got blissed out and then everything was fine. It was very much recognizable, often painful revisiting of trauma in therapy. So the MDMA didn't make it easy, but it made it possible for people who had not been able to do it before. So just a few quotes from people that sort of what they said about this point. And I won't read the English, I'll just let you read the German. Good? Tell me if I go too fast. When I read German, it's very slow, but you're probably faster. you know, I thought it was really an important point that it changed, people would say it changed my relationship to my emotions. It didn't take them away. So the results of the first study, kind of in a nutshell, the CAP score is on the vertical axis, and these time points are the baseline before treatment, 3 to 5 days after the first session of MDMA or placebo, 3 to 5 days after the second session, and then 2 months after the second session. So you can see the baseline was just under 80. That's a high CAP score. That's severe PTSD. And the placebo group actually had a fair amount of improvement, 22 points, I think it was. So, and that was actually turned out to be statistically significant, but it's still severe PTSD. This 50 was the cutoff for study enrollment, which 50 is equivalent to moderately severe PTSD. So the placebo group, you know, we call it the placebo group. It's actually the therapy-only group because they had all the same therapy, all-day sessions with us. We did our best to support their process, whether they got MDMA or not. So it made quite a difference for people, but they still had a lot of symptoms. This is what happened with MDMA. You can see the MDMA group started at almost the same place. They had a dramatic drop in symptoms even after one session, and that continued to be a split of about 33 points better than the placebo group, and it was a 55-point reduction in the CAP score overall. Just to give you a sense of the CAP score improvement, in sertraline, which is one of the 2 drugs approved by FDA for PTSD. It was the first one. In the sertraline trials, sertraline was a little less than 7 points better than placebo. And here we have 33 points better than placebo, and the placebo got treatment also. So it was significant. So we were very encouraged by that. Then for the crossover, that was the open label stage. In the crossover stage, where the people that had had placebo got MDMA, 7 of the 8 people chose to do that. And, oh, I didn't mention this was a highly statistically significant change, even in only 20 people. So in the open label, in the crossover session, people, as I said, got MDMA. If they'd gotten placebo, the same integration sessions following it, same schedule. And here's what happened. So this was the original baseline of the placebo group, the first point. This was the CAPs for these 7 people after they'd had all the therapy without the MDMA. And then here's what happened when we added the MDMA. So they ended up in about the same place. So once it was good because it showed that this was not a more treatment-resistant group. They responded just as well once they got MDMA. And just to show you well, that was statistically significant. And that was the original curve you saw on the other slide. So both groups got to the same place once they got MDMA. So in terms of looking at clinical significance, which is often defined as greater than 30% improvement in CAPS, in the stage 1, 83% of MDMA people had a significant improvement versus 25 with therapy only. And then when the 7 people crossed over, all of them had a clinically significant improvement and didn't meet criteria for PTSD anymore. So the other thing we did, because of the controversy about could MDMA be neurotoxic, some studies in recreational users raised that question. So we did neuropsychological testing before and after MDMA and placebo. The main test we used was the R-bands, which is a comprehensive neuropsychological test. We also did the PASAT and the Ray asterisk complex figure test. The results for all of them were similar. I'm just going to show you the R-bands because that's the most comprehensive one. So R-band score, higher is better functioning. You can see MDMA on the left, before and after, placebo group, before and after. Slight trend toward improvement, definitely no sign of any neurotoxic effects. This study, of course, has limitations. It was quite small, only 20 people, and the blind was problematic because we were pretty good at guessing what people got. Unlike most of the pharmaceutical companies, when they do research, they have a kind of don't ask, don't tell approach to the blinding. They'd rather not know how effective it is. We actually had to record after each session what we thought they got. The participants had to record it, so we looked at it, and yes, in fact, not surprisingly, we could guess. The subjects, we weren't always sure, but we were always right. The subjects were not always right, but usually they were. So part of our way of addressing that was to go on and do a long-term follow-up study, because, you know, placebo effect isn't expected to last over years. So what we did was, this is the paper we published about this. 1 year or more after study completion, we repeated all the measures, or these 3 measures, and also a questionnaire that we made ourselves. So just to understand the data, I'm going to show you this. We actually enrolled 23 people and had 2 dropouts, which left 21, and one of those was not treatment resistant because he hadn't had treatment, so he was kind of an add-on. So the 20 people that we originally intended to that met all the criteria are the ones I'm going to talk about, and then one of those only got placebo. She chose not to go on. So we ended up with 19 people who received MDMA in the long-term follow-up, or had received MDMA who we're looking at in the long-term follow-up. And of those 19, all of them filled out the questionnaire, but only 16 completed the CAPS. But here's what we saw. This was the original baseline CAPS score. This was the CAPS score for these 19 people at the 2-month follow-up at the end of the original study. And this was the CAPS score, mean CAPS score for these 19 people 3.5 years later. It was a mean of 45 months, minimum 17 months. And 2 people in this group did relapse, but their numbers are included here. So on average, people, if anything, continued to improve 3.5 years later. So we thought this was pretty suggestive that it wasn't just because they could guess they had MDMA 3.5 years before. So if you look at this, if you look at just the CAPS, the people who completed the CAPS, that would mean that 88% had sustained improvement. Since we don't know what the CAPS would have been for the other 3 people, to be conservative, if you look at, consider that all those 3 people that didn't repeat the CAPS, if they all relapsed, it still means 74% durable improvement 3.5 years later. Actually, looking at the questionnaires, it doesn't seem likely that they all relapsed from what they said, but that wasn't a validated instrument. So, so our ongoing research in Charleston, we're doing several things. We're almost finished with a new study with mostly veterans from Iraq and Afghanistan, but also firefighters and a police officer. It was limited to those 3 groups. So I'm going to tell you more about that. We're also have a protocol that allows us to legally give MDMA to therapists who are going to work on clinical trials. And we've had 8 therapists who've been through that so far, and that's an open protocol because, you know, most of the people who started doing this research had already experienced MDMA, but there are new people wanting to come into it, and we thought it was really important to have a legal way for them to have their own experience so that they know what it's like and they can trust the process. So that's what we're doing in Charleston. There's a study in Israel, similar to our first study, but a little smaller. There's one in Boulder, Colorado, that's almost completed as well. These are all for PTSD, and one in Vancouver that's almost complete. Those are all MDMA PTSD studies sponsored by MAPS. They're also, the main focus of MAPS is MDMA for PTSD, but we also, there are a couple of other studies going on, one at UCLA with adults with anxiety associated with autism. Charlie Grobe is doing that, and that's going well. And then there's one in the San Francisco Bay Area using MDMA for people with life-threatening illness with anxiety, kind of like Peter Gosser's study. And there are studies, protocols under development now in England, Germany, and Australia. So it's really, really happening more and more. So I want to give you kind of a preliminary look at what we're seeing in our current study that's almost finished. Everybody's actually had all their MDMA sessions, but we haven't done all the follow-ups yet. So this is somewhat preliminary, but it's almost finished. So this is the one I was talking about, veterans, firefighters, and police officers with treatment-resistant PTSD. And the therapeutic method is exactly the same as I described for the first study. The main difference in this study is people are randomized to either low dose, 30 milligrams, medium dose, 75, or full dose, 125. And each one is followed by an optional supplemental dose of half the original dose. So this was really an attempt to see if there's a dose that would fool us, be better for the blind, but not be effective. As we kind of suspected, it doesn't really look that way. Either people have an MDMA experience and they get better, or they don't. So it didn't work as far as the blinding goes, but it's been a successful study. So same thing, 8-hour all-day sessions with us and similar kind of follow-up sessions. And then in the stage 2, the open label stage, if they got full dose, the first two, we do the first two, wait, break the blind, repeat the measures, break the blind, and then if they got full dose the first 2 times, they can go on to one more full dose session. If they got low or medium dose the first 2 times, then they can go on to 3 full dose sessions, open label. And then we're doing outcome measures at 2 months and 1 year. So we're also, our primary outcome measure is again the CAPS, but in the first study, not surprisingly, people described a lot of benefits that went way beyond just their PTSD symptoms being better. So they weren't captured well by the measures we were using, and so we attempted to at least improve that somewhat. So we're doing these other studies, the Beck Depression Inventory, the Global Assessment of Functioning, the Post-Traumatic Growth Inventory, the idea that if people can successfully, deeply heal from trauma, it doesn't just put them back where they started. It's not just that their PTSD symptoms get better, but there also can be a lot of other growth. So there's actually, we found there's a scale to measure that's validated. So we're doing that. And also, people with PTSD really have a lot of sleep problems. So we're using the Pittsburgh Sleep Quality Index also. And also in talking to Roland Griffiths at Hopkins, their results have correlated strongly with mystical experience, so he encouraged us to do this measure too to see if that's true with MDMA, which it does not seem to be, even though sometimes people have quite strong spiritual experiences. Other times they don't have it at all and they still get better. And then we're still doing the neo-personality inventory again. So just kind of a brief look at what we're seeing so far. This is the CAPS scores. In this study, the baseline CAPS is actually a little bit higher than in the first study. And you can see the blue is the low-dose group. A little bit of improvement, but not that much. And then the purple is the full dose, and this is the 75. So both the full dose and the 75 had marked reductions in CAP symptoms. It was kind of a surprise that the medium dose group is actually doing better than the full dose. Whether or not this would hold in larger numbers, I don't know. I think the main point is they're both very effective. But it is interesting that the processing seems to be a little different for many people with the medium dose. They're a little bit better able to track their thoughts process, and it seems particularly good for some people who are very anxious about losing control. So maybe the 75 is a little easier. And you know, as Peter and I were talking yesterday, it's striking that we're seeing these young people who were in Iraq or Afghanistan, sometimes for 2 or 3 tours. They're used to having people trying to blow them up and shoot at them. But what was even more scary for some of them was the idea of letting go of control. So in a way, maybe 75 was a little gentler introduction to their trusting that. This is the Beck Depression Inventory. Higher is worse depression. You can see no real change in the medium dose group. Quite a bit of change in the full and medium, and yeah, did I say that right? Yeah, no change in the low dose, quite a bit of change in the full and the medium dose. It's interesting that the full dose group had much higher depression scores, so that may have something to do with why they didn't respond quite as much on the CAPS. To us, one of the important things about this is, you hear folklore about Blue Tuesday or Blue Monday or whatever, people using MDMA recreationally get depressed later. And I've heard people say, well, they must have run out of serotonin, or, MDMA causes depression. Well, apparently not. And within this data, there were no individuals whose depression scores went up. So if they were low, they stayed low. If they were high, they came down. So that was encouraging. This is the Pittsburgh Sleep Quality Index. With this scale, lower is better sleep. Good sleep, really good sleep, is 5 or below. So you can see they all had really terrible sleep. And didn't improve in the low dose group. If anything, perhaps got a little worse. But there was quite significant improvement in the other 2 groups. And, in order to be in the study, we required that people taper off all psychiatric medicines beforehand, because a lot of them were on antidepressants, benzodiazepines, even antipsychotics. Quetiapine is very popular with the Veterans Administration to help people sleep, even though it causes metabolic syndrome and kills them eventually. So people came off all these medicines, and so many of them reported that after the study they were sleeping very well with nothing. And they, beforehand, when we did the screening, we didn't require them to come off their medicines. So even with the medicines, their sleep was terrible. And for most of them, it was vastly improved without any medicines. Let's see. And then the post-traumatic growth inventory was pretty interesting too. No change in the low dose group, and really very strong post-traumatic growth in the full and medium dose groups, equivalent amounts. So this is just a summary of the effect sizes for the different studies at this point. The first 2, the first one is our first study. This is Peter and Verena's study, the second one. So they both, 1 or greater is very strong effect. So even though, as Peter said, his CAP score didn't reach statistical significance, it was only 12 people. And if you look at the effect size is a good way to compare across studies. And they also had a very strong effect size. These are preliminary for the other ones, the ongoing studies. Our study in Charleston, study in Boulder, and with the 2 different doses. So overall, we're getting even stronger results in the second studies, and now validated in a different site. So it's looking very encouraging. So what are our plans for the future? We're basically all these phase 2 studies are moving toward phase 3 studies, which is basically the same thing but much bigger. And the FDA requires 2 phase 3 studies in order to apply for approval as a clinical medicine. And these studies will be between 200 and 300 people each, and will occur in multiple sites. So what we're aiming for is 1 phase 3 trial in the US and Canada, and another phase 3 trial in Europe, and possibly some of the sites in Israel. And we're by the end of this year, we'll have enough of the phase 2 studies finished that we'll have a meeting with the FDA, and we'll agree upon the numbers and the protocol for phase 3. So we hope that the phase 3 trials will start in 2017, hopefully early 2017. And Rick's Doblin's projection of when MDMA is going to become legal for clinical use is 2021. Of course, when we started in 2000, his prediction was 5 years. So he's very good at making the studies happen, not necessarily good about predicting the time. But I think it's getting more realistic because we had so many regulatory delays for the first study. And as I said, now we're not encountering that. We never did have really undue delays from the FDA, but now the DEA and the IRB are much more comfortable with what we're doing. So I'll just let you read a few quotes, other quotes from the study participants to give further kind of feel for what their sessions were like. Yeah, that was from a veteran from Iraq. Oh, slow. Okay, I'll go back. Good. Good. You know, this last one makes an important point. Maybe one of the most important things we learned from Stan Grof, in addition to trusting the person's own inner healing intelligence, is that the process keeps unfolding for days, weeks, months, maybe a lifetime. So we really emphasize to people, you know, it's not just what happens during the period of MDMA effect. Sometimes some very dramatic changes happen very quickly during that period and are real. but much of what happens is what continues to unfold afterwards, and that's what this person was speaking about. So, you know, just thinking about these quotes and the people that have been in this current study especially, you may know right now, every day, 26 war veterans commit suicide in the U.S. every day. And we had people, unlike a lot of studies, we accepted people who had a history of suicide attempts. We had people, one man had had 5 serious suicide attempts. He'd been hospitalized and almost died. Another woman had had 3 serious attempts and been hospitalized before entering the study. Other people had had strong suicidal thoughts and some attempts. So we took people despite that, and many people told us this saved their lives. You know, some people said, you know, I was definitely going to commit suicide when my cat died, one person said. And so it was very moving to hear their responses. So thanks very much again for allowing me to speak. Thank you. Thank you.
So thank you, Michael, for presenting this remarkable and groundbreaking research to us. Thank you very much. We now have time for questions. Also, wir sind gut in der Zeit und können jetzt Fragen stellen. If possible, please pose your question in English. If not,
Peter will translate.
We'll try to translate.
I have a methodological question. I understood that in 2 hours the subjects got 125 milligram plus 62 milligrams of MDMA, right?
Yes.
Which is 190 in total.
The second dose was optional, so not everyone got it.
Okay, but anyway, I cannot imagine that a professional like you will not find out who of the subjects got 125 milligrams of MDMA and who not.
Right. That's true.
I think you will definitely, in 100%, you will find it out.
Yes.
Right?
Yes.
Thank you.
That's one of the challenges of this kind of research.
I have 2 questions. One is, did you ever consider making more interventions, like, 5 maybe, or something like that? What's the reason to limit it? And the other one is, if I'm correct, there's also been work done with mindfulness-based stress reduction with war veterans. Do you know how the results compare?
The first question, the reason for limiting, we don't presume that this is the ideal number of sessions for everybody. It's partly a regulatory matter. We didn't think the FDA would allow us too many sessions at first before we have more data, and also a practical matter. This is all sponsored by a nonprofit, and they have to raise the money to do it, and time consideration. So it's a practical matter to see how well this number of doses would work. When it gets approved, of course, it'll be a big advantage to be able to adjust that according to the individual. And I'm sure that for some people, more sessions would be better. I know about the mindfulness-based stress reduction studies are going on, but I don't know how this data compares. Well, I'm thinking about it. Can I come back to your question for a minute? Yeah, it is an inherent problem. We, of course, attempt to support people in the same way, whether we think they got placebo or not. That's not very reliable. But we videotape all the sessions, and we have trained raters with adherence criteria, and so they watch our sessions, and rate whether we're doing what we say we're doing, regardless of whether people got full dose or a placebo. And they're also rating the videotapes from all the studies to make sure everyone is using the same basic approach. You know, it's a word about the manual. When we started out, I didn't like manuals. I still don't really. And I thought it was impossible to make a manual about this therapy. So, because it's so variable and intuitive and flexible. But we decided we could describe that, you know, sort of describe the essential elements of the approach, which I think we've done fairly well in the manual. But it's not rigid, you know. We don't just sit there and not talk. When people are talking to us, if things come up, we can work with that any way we think is appropriate. So sometimes there's quite a bit of interaction with the therapist, and that can be very important too. But the main thing is not to impose that on them, to let their own process lead the way, and then we support them in whatever way seems helpful.
Bitte.
I'm part of the young generation of therapists who hope to one day in the future maybe legally offer substance-assisted psychotherapy for patients.
Great.
Well, I once heard an interview with Rick Doblin, and he said that was his goal at the start, and he kind of became activist because he realized it wasn't possible yet. And I hope to see this happen in my lifetime still. And my question would be, what can I do so long to help the process along? Number one, besides coming to conferences like this and reading and subscribing to maps, maybe donating money, which I also did. And secondly, how do you foresee that training for therapists will happen? Like, how will it be regulated, or how might this, you know, actually realize?
Thank you. Yeah, thank you for your support, and I'm always very encouraged about the number of young people that want to do this, because we're not getting any younger ourselves, so there's a lot to be done. As far as the, you know, if you keep in touch, MAPS has an application for people that want to work on phase 3 trials. You can go on the MAPS website and find that, and then if it turns out we can have a study in a phase 3 trial in Europe, that's a possibility. As far as the training, we're spending a lot of time on that now. We've had a training program that involves mostly watching videotapes from our sessions in groups and discussing them. It's been a 5-day training in the past. We're about to do another one in October, and it's going to be 7.5 days with an online interactive component first. So we're expanding it quite a bit, and so, you know, those will be happening. We're kind of gearing those up, looking toward phase 3. We did one in England in December, so there will be more happening in Europe if we are moving toward phase 3. And there may be some trials. There's a trial under development in Berlin now, so if that happens, that would be another possibility. So we welcome you to participate, and it's not certain exactly what that'll look like, but you don't have to go back to starting an activist organization. Thanks to Rick, you can move right into therapy. Thank you.
In both studies you were saying that the patients were treated for a long time in some kind of psychotherapy. Was this a kind of specific trauma therapy, or was it just, do you have any information about that, which kind? Because from a trauma therapeutic aspect, one would say, well, EMDR, for example, is very effective, and which patients did you treat?
Yeah. Well, that is not as strong as it would be, in that we didn't have everybody go through some kind of very structured trauma therapy. The rule was they had to have had at least 6 months of one of the therapies recognized by the American Psychiatric Association for PTSD, which is prolonged exposure or cognitive processing therapy, EMDR, or psychodynamic therapy. So it was mixed. Not, you know, some people had better focused trauma therapy than others. And in the second study with veterans, in the first study they had to have failed medication and therapy. In the second study it could be either or, because the reality is most of the war veterans don't get much psychotherapy. They get a lot of medicines.
There is room for the very last question. Thank you.
Oh, there was somebody over here.
Oh! What about?
I would like to ask you, how did you find the people which apply for the research, like probants?
Yeah, in the first study, it was not so easy to recruit. We sent letters to therapists in the southeast region, and MAPS did a little bit of internet advertising. In the second study with veterans, we didn't have to recruit at all. For this study of 24 people, we've had more than 700 people contact us from hearing from word of mouth or reading in the media. So it's really heartbreaking in a way that the need is so great that we didn't have to look for them, they looked for us.
Thank you again, Michael.
Thank you.